Good evening, everybody. Welcome to another episode of Epidemic Watch. Today, we have a speaker who doesn't require an introduction, Dr. Rajeev Jayadevan. Dr. Rajeev Jayadevan is a doctor, a public health professional, an epidemiologist, and doesn't require much of introduction. He has been trained in multiple countries, in Europe, followed by the US. And he is an extremely well skilled orator. He has been a very good public communicator, not just during the COVID pandemic, but also before that. He has championed a variety of social causes, including prevention of road accidents, noise pollution, teen alcoholism, tobacco use. And he was also occupied the chair as the president of the IMA of Cochin, and now is in the task force of the IMA COVID program. So today I invite you to this session on breakthrough infections, reinfections, and vaccine boosters. What does the evidence say? The stage is all yours, Dr. Jayadevan.
Thank you, Dr. Vinod. An honor to be invited to speak in this forum. The title of my talk is Reinfections and Boosters. Where does the evidence lead us? So I will be presenting some of the newer evidence that is applicable to the present day. And as all of us know, the pandemic is a fast-moving phenomenon, and what is applicable today might not necessarily be relevant a few months from now. But I think it's very important we stay on top of emerging evidence, because the narrative now has completely changed from what it was in 2020 or even 2021. Are you able to hear me?
Yes, it's perfect.
Okay. I'll start with some local information, because we need to have information pertaining to our own population. So this is some of the work we did in the past month following the third wave in India. So this was an all-India survey that we did on close to 6,000 individuals. We received input from people all over India, adults of all age groups. And that gave us plenty of insight on how our people went through the third wave. And specifically, we wanted to know how they did with the third dose, and what specifically was their response according to the gap. So I'll take you through some of our findings. The Hindu reported on our study. This was on 27th April in the state edition by C. Maya. And then Mr. Prasad reported in detail on that's a week prior. So these are our findings. In blue, you can see healthcare workers, and green is non-healthcare workers. We can see that there are plenty of people who have not got COVID yet in our country. And at least they believe they have not got COVID yet. And then you can see in the middle, you can see the first wave or the previous waves, and this is the third wave. So clearly, the size of the third wave, at least according to the survey, is larger than the previous waves. And that correlates with worldwide experience, where the number of people infected during the third wave is larger than the previous waves. This is our age distribution. I'll explain the graph, how it works. Now, this is the age group, less than 40 and then greater than 80. We had an equal distribution of age group, which we were very fortunate to get people over the age of 80, people in the 60 to 79 age group, which is extremely important. And we had a good representation as well of people less than the age of 40. In fact, our distribution was almost normal. We were very pleased with the outcome from that standpoint. And within that, this graph looks at, if you were under the age of 40, what percentage of respondents tested positive in the third wave? So among the below 40, a high percentage tested positive, whereas that percentage dropped with each passing decade. As you can see, among people in the 60 to 79 age group, only 32% tested positive. So this we attribute to greater social mingling in this active age group. And also the reverse, that is, people who are older tending to be a little bit more careful not to get infected. How severe was it, was a question we asked. And since there is not a lot of time, so I will just take you through just the main findings. The most significant observation we made was about 42% were moderate severity. And we defined, for the purpose of our survey, we defined moderate as those who required bed rest or hospitalization. Now, as you know, many individuals during the Omicron wave in their 20s and 30s were hospitalized because they were throwing up, they were dehydrated, they required IV fluids, but they were all home within a couple of days or maybe slightly longer. So hospitalization and bed rest were taken as the severity marker as moderate. And severe, we defined as anyone who required oxygen supplementation. So that was easy to do on a survey. And in our publication, we have in fact shown the wording of the question, so it is unambiguous. So this was one of the big findings in our surveys. There is a common narrative that Omicron is nothing. It is a common cold. It is not. It's of no consequence. But imagine if a wave of infection sweeps across a country and 41.5% or 40% develop, sickness, illness severe enough to give them bed rest or hospitalization or IV fluids. Yes, that is not good. So this can cause an incapacitation of services across any country. So this is something we must be very careful about with future waves. We asked a question about how many times they were infected with COVID-19 in their own assessment. So most individuals belong to the one category. Close to 500 said they were infected twice, and a handful of individuals said 3, 4, and even 5. Now, we did contact a few people wherever contact information provided, and it was true. And in some instances, these were self-reported, and not in all cases was it actually confirmed, because as you know, testing really came down in 2022 compared to 2020. So in any case, this gives us an idea that basically 15% or greater than 15% of all infections were infected at least twice. So I think we can safely assume there's a lower end of the estimate at around 15%. So in other words, at this point in time, around 15% of COVID infections in the country would have been at least twice infected. We asked them what vaccine they received, and both the mainstream vaccines used in India, Covishield and Covaxin, had identical percentage positive in the third wave. There was no difference at all, not only about the type of vaccine, but also specifically we asked them when these were used as a third dose. So that's where we are. So again, this was one of the high points of our study that looked at We were looking at third dose versus no third dose, people who received a third dose versus no third dose. And we found that the percentage of people who had got the third dose had 30% of them had turned positive, and 45% was the percentage in the no third dose group, people who did not receive a third dose. Now, this may seem rather dramatic, but I must add that this is a survey. This is not a randomized controlled trial or a case controlled study. And we also found two important confounders that could potentially impact this 30 and 45%. So I'll take you through this graph again. The third dose group and, or let's say booster group and non-boosted group. This is vaccinated with 2 doses. This is vaccinated but with 3 doses. You can see the percentage who tested positive was greater in the boosted group. Was lower in the boosted group, but we found that the third dose group also had a high percentage of healthcare workers who were also using N95. So N95 may have contributed disproportionately to the protection in that group. So it might not have necessarily got to do with only the third dose. So that's the point here. Again, there's an important area to address because confounders can actually exaggerate or minimize findings, as all of us know. This was one of the remarkable things we found, that the longer they waited after the second dose, the more likely they were to be positive in the third wave. And we also went on to ask them, when did you receive your second dose and when were you infected? We found that people who got a third dose long after their second dose had an apparently additional protection, whereas people who took their third dose very close to their second dose. So these were two groups who got the third dose too close to the second dose, and they did not have any additional benefit. Now, these are trends, I think, but I think these trends are pointing in the direction of science. So I'll explain this graph just once more. The longer you wait after the second dose to give your third dose, the more the apparent benefit was in preventing infection in the third wave. This is a graph that looks at the boosted and non-boosted groups in terms of severity. So here's the asymptomatic and here is a severe. And you can see that the pattern is roughly the same. So we can see the pattern actually goes like this. It follows a bell curve. There's hardly any difference. These are insignificant differences. In a survey, you will find plenty of insignificant differences. So this was our effort, which is now in medRxiv. And you might remember the same group, that is myself, Ramesh Shenoy and Anita Devi. We are the team that actually published on the symptoms after COVID vaccination in India. This was done on around 5,000 healthcare workers soon after vaccines were rolled out in India. And we found that people tolerated it very well, but we also found that we could tell people what to expect, and that greatly enhanced vaccine acceptance in India, because this was real world experience, not just published data from companies. So we showed them that if you are a young person, especially if you're female, you could develop fever or a bit of body ache or a headache for a day, a maximum of 48 hours and nothing beyond that. And that was the main point of our study. We also found that 20% of individuals required a day off work the next day. So that again was a significant contribution we made. Our study has received 27 citations and has also been replicated independently by multiple individuals, Dr. Naresh Trahan's group from Delhi, and also by a Bangalore-based group. I think it is Baptist Hospital group from Bangalore. They produce identical results that we had published on the 12th of February last year. So I'll take you through some of the recent papers, and most of them I have described on my Twitter as well. My Twitter handle is my name, Rajeev Jayadevan. So what I've done for the remaining part of the presentation is that I've given some taglines, so it makes it easier for you to follow. Say, for example, this this section I've called it Omicron can infect a high percentage of recently boosted adults. Now, since I want to cover as many points as possible, I'll be brief with the description of each item, because I could go on forever for each point, but I think that will take away the number of topics we discussed. So the first in that series is this statement: Omicron can infect a high percentage of recently boosted adults. And these are two major papers that we need to look at. One is already published. Both in fact are published. This is from Faroe Islands, which is near Denmark. A published paper that shows that 64% of recently boosted individuals, mRNA vaccine, Pfizer, got infected at a social gathering, and they were all symptomatic with body pain, fever, headache, and so on. Identical results were published in Italy. The paper on the right that shows a near identical group of healthcare workers, but this time in Italy, they went for a Christmas dinner, and 65% of them came down with symptomatic Omicron infection. In both instances, the group was relatively young, and predictably there was no mortality and there was no hospitalization. But they did report these symptoms, that is fever, muscle and joint pain, and tenderness. So this shows the penetrative power of Omicron past your boosted defense. So an important message to the community would be, even if you've taken a booster, please do not consider yourself bulletproof. You could pick up an infection should you get exposed to sufficient viral load, especially in an indoor setting. We know that virus travels in droplets, and I've put out a fascinating physics thread yesterday on my Twitter. There's no time to discuss it today, but I'll invite you to read that thread. It just says physics of the pandemic. I've put out a series of tweets over the last 2.5 years on the physics of the pandemic as to how this is produced. In fact, I was one of the first who described how talking can produce droplets back in April of last year. That's 2020. I put out an article based on how that's possible. So physics is extremely important here. To cut a long story short, I'll say this: if we are trapped in a room full of people who are talking without masks, you will most likely be infected, and that is a fact that's been shown in both of these studies, well documented and published. The second point is Omicron is not mild even among triple mRNA boosted young adults, because most of the world's published data still remains among triple mRNA boosted young adults. That's why I use this subgroup. And I'll take you through this tweet from yesterday of Dr. Maleki, who's a well-known young immunologist in the United States. So Dr. Maleki shared his experience after suffering Omicron breakthrough infection after 3 doses of mRNA vaccine. Now, this is Dr. Maleki's tweet. Let me take you through this. He said he went to the hospital with fluctuating blood pressure, dehydration, vertigo, terrible headache, and so on. Then he said that they found him to be lymphopenic. He obviously knows all this, being an immunologist, and then he said he became anemic. His red cell count dropped. Fortunately, he did not have to stay too long in the hospital. He says that I started having these ungodly COVID fatigues that you can only describe to someone who got COVID and has experienced it. This is so profound, the way he's described it, so elegant. And I've heard this story a million times from people, especially younger, healthy individuals who've suffered Omicron and were surprised at the intensity of the illness. So he calls these ungodly fatigues that you can only describe to someone who got COVID and has experienced these. And this is a message that we must send out. Don't take this infection lightly, because it can take you down and can capacitate you. And when a lot of people are incapacitated at the same time, it can affect the productivity of an entire nation. So this is not something that must be taken lightly. The next point I want to say here is that Indian vaccines protect against Omicron. I will take you through some of the data. Again, very recent. This is a Zambia prison outbreak study. You know, over the last 2 years, there have been several prison outbreak studies. As unfortunate as it is, because prison is basically a captive audience, literally, where people do not have a great deal of mobility. They live as a community. So it's also easier to track them and to study them as a group. So prison outbreak studies have been quite revealing in the study of this pandemic. And I will also remind you of the minors study, the study of minors following Pfizer vaccine that came out shortly after the vaccine rollout in 2021. So this, again, coming back to this study, it shows that in Zambia, they found that they were using adenovirus vector vaccines, and I'll zoom this in for you. And in this case control study, they found that people who received AstraZeneca, it was not a very large group. Most of the individuals had received the Janssen vaccine, but they found a high percentage of protection by AstraZeneca's vaccine. So that is good. And what they also found was what I alluded to earlier, the longer they waited after vaccination, the smaller the protection was. So the protection actually dropped as they waited longer after the vaccine. So this is one observation from the study. And then so this was the AstraZeneca paper. There are plenty of papers. I'm just giving you one representative paper for each statement here. Indian vaccines are effective as boosters. They are as good as mRNA vaccine because, as I mentioned before, most of the booster studies are still based on mRNA vaccines. So that's why I use the statement, the vaccines that are used in India are also effective as boosters. And this is one paper that was put out by the UK Health Security Agency. And they found that AstraZeneca's effectiveness as a third dose equaled that of Pfizer vaccine when used as a third dose. And they also found that the reason they could not use AstraZeneca for many people, whether there were several contraindications. So, and the AstraZeneca or the Covishield, or let's say the ChAdOx1 vaccine, ended up being used for rather ill people whose baseline health status was lower than that of the Pfizer group. So, in other words, the AstraZeneca group was sicker at baseline. They were classified as clinically extremely vulnerable and also immunosuppressed. And they had the same effectiveness as the Pfizer vaccine as a booster. So that is why I said that it is at least as good as the Pfizer vaccine when used as a booster. So this is helpful information for those in India who are requiring a third dose. And specifically, this study pertains to AstraZeneca vaccine. I don't have comparable studies on inactivated vaccines, but I can also say that in our study, when we looked at the people who took Covaxin and Covishield, there was absolutely no difference in the third dose positivity or in their severity profile. Now, as I mentioned, our study was not an effectiveness study, but again, it showed trends. The other important discovery this year is that the gap between the unvaccinated and vaccinated is closing. This is, again, I showed you the slide earlier about the Indian data, Covishield, Covaxin, and we also had a small group of 109 people who were basically expatriates who were in and out of the country, who had taken a third dose of other vaccines, 109. They also had exactly the same percentage positivity during the third wave. So the vaccines used in India were all equal, at least according to our findings. Now, this is a study which I want to spend some time on. I said the gap between unvaccinated and vaccinated is closing. This is a statement that we need to verify as we go along, look at multiple papers, but This is a very, very well done paper that I wanted to go through in great detail here with you. So this is put out by the UK Health Security Agency. They basically compared Omicron and Delta. So first, I will explain the fundamentals of the graph. Ignore my annotations. This is something I do for Twitter. For people who like to read articles on Twitter, I annotate most of the slides that I use, so it's easier for them to follow. It saves them time, which is what I would want to see if somebody else was reviewing a paper. So let's just look at the graphs for now. I'll explain the graphs first, and then we will go into the findings. These 9 boxes are, this is an age group, young age group. This is age of 40 to 69, and this is 70 plus. You're with me. So this group is no comorbidities. This is 1 comorbidity, and this is 2+ comorbidities. So you're with me now. So this means that this is the healthiest and the youngest group, and this is the oldest and the sickest group. All right. So now let's look at these dots. What are these dots showing us? So let me zoom in a little bit more here. Let's look at this graph. So what they have done is they've looked at the absolute risk of casualty attendance, or A&E, accident emergency attendance, following the diagnosis of Omicron or Delta. That is, in plain English, I've annotated here, you are COVID positive. How likely are you to go to casualty? So that is a plain English question that this slide is answering. So let's go through this. Let's go through the first column here, for the first box here. These are young adults and also includes children. Again, let's look at what these dots are. The blue dot is basically Omicron. So Omicron, you can see this is unvaccinated, 1 dose, 2 dose, and 3 dose. I hope you're with me. So in this age group, these 4 lines, 1, 2, 3, and 4, are unvaccinated, single dose, 2 dose, and 3 dose. And this horizontal line is the chance or the absolute risk of going to casualty. So if this group was tested positive, how likely were they to attend casualty? So that was that's what this graph is about. So let's just erase all that out of the way. It's very important we understand this graph correctly, because otherwise it will not be possible to explain this. All right, so here we are, the unvaccinated group. This is the 3-dose group. This is the 3-dose group. Now in the 3-dose group, or in the Omicron group, Omicron is blue and Delta is green. So let's draw the Omicron group. So I'm going to use a blue ribbon. I've created a blue ribbon here. See, the blue ribbon is vertical. See that? Whether you're unvaccinated, single dose, second or third dose, the risk is the same. There is a chance of going to casualty with the diagnosis of Omicron. Now, let me take that away and then show you the Delta. Now, let me draw a Delta ribbon for you. So there is Delta. You can see the Delta ribbon is slightly tilting to the right. You can appreciate that. Now, as I add comorbidities, you can see the Delta graph is now shifting to the right. And as I look at the same young people's group with more comorbidities, they are more likely to, you can see the 3 ribbons are gradually slanting. So this basically means that as the sicker you are, or the more illnesses you have, if you are having, say, Delta infection, there is a clear difference between the unvaccinated and the vaccinated groups. I hope that's clear. Now let's take away all those ribbons, and now let's look at Omicron, which is blue. Now I'm going to draw the Omicron ribbon. Omicron ribbon is dead vertical in all the 3 groups here. You see that? Below the age of 39, it made no difference whether you are vaccinated, unvaccinated, single dose, triple dose, boosted, whatever. Now let's look at the other age groups here. So these age groups for Twitter, I've actually labeled it, so it's easier now. Again, blue is Omicron. You see, for blue, nearly all the blue ribbons are vertical. Even in the 40 to 69 age group, they're all vertical. Now, as you get into the geriatric age group, that's age 70 plus, you can see that there's a clear difference. If you are, let's say, Delta, which is green, there's a clear difference. You have unvaccinated, you are at much higher risk of attending casualty compared to someone who's vaccinated. But when you look at healthy 70-year-olds, if I draw the Omicron ribbon again, there's no difference. It's near perfect vertical. So in other words, according to this large study from UK Health Service, Health Security Agency, unless you are older and had substantial comorbidity with Omicron, vaccination did not make a difference in the outcome of severity they were measuring. They were measuring what are the chances of you going to casualty. I know there are plenty of caveats here. Not everyone who goes to casualty has severe disease. They may be going for some IV fluids, and all people who go to casualty may not have COVID pneumonia, but this is a space that we need to watch. This trend is something we need to watch, because this will decide our policies in the long run. Now, I'll take you through some data from Mississippi in the United States. Now, to explain this graph, this is the 50 to 64 age group, and this is the 65 plus age group. And the three bars are the unvaccinated group, that is the dark blue bar, unvaccinated group, mortality per 100,000, and this is the 2-dose group, and this is a 3-dose group. So in the 2-dose group over 65, the mortality is 1.5 out of 100,000. In the 2-dose group, the mortality is 0.8 divided by 100,000. You see how small these numbers are, and it's about 7-fold higher in the unvaccinated group. So clearly in the 65 plus segment, being vaccinated made a difference in the mortality. And between the 2-dose and 3-dose group, I would not call this a significant difference, because the denominator is so big that it is like looking at the difference between your right hand and your left hand. They look the same, but if you measure the difference with the caliper, you may find a millimeter difference. But below the age of 65, you can see how remarkably similar the three groups are. Whether you are unvaccinated, whether you're 2-dose, whether you're 3-dose, the mortality is extremely low in Mississippi. Mississippi I chose because for two reasons. One, they have a large percentage of unvaccinated people in adults. Among adults, about 48% in Mississippi, United States, are still unvaccinated. It's among the most unvaccinated regions of the United States. So their mortality, again, it gives us an opportunity to compare the groups. That's why I picked that state. And also, they have good, very well documented databases. You're welcome to look at their database as well. This is all public domain stuff. Now, the next point is that Omicron deaths are equaling or exceeding Delta deaths. We are all given the impression that Omicron is a common cold and it is not killing people. So it is the pandemic is a hoax. The pandemic went away, and people are just making unnecessary noise about variants. That's not true. If you look worldwide, the number of Omicron deaths are exceeding or equaling Delta deaths. So I'll take you through a couple of slides to illustrate my point. This is the United States, and the graph shows the orange section is the number of COVID ICU beds occupied. See, in the three big waves that the United States had, you can see the numbers being the same. It is the same country, same systems, so you can compare the three seasons or three waves. You can see whether it is Omicron or Delta or prior, the occupancy of the COVID ICU beds was the same. And you can see that after this 2022 in multiple nations, you can see, if you see the color code here, I don't know if you can see that. Maybe I'll enlarge the graph for you. Let's see that, see if we can enlarge it for you. I hope that's clearer. You can see this is the 2022 New Year. You can see whether it is Germany, US, Australia, Taiwan, Spain, other nations, the outcomes for 2022 are worse. So this is unfortunate. And again, if you look at US and Israel, if you look only at deaths, you can see that the number of deaths is in fact quite high in the 2022. And again, Israel is a tiny nation that has a high percentage of vaccination, and not only a high percentage of vaccination, a high percentage of booster doses, and a high percentage of extra booster doses. Again, you can see the number of deaths that are being logged in that country. So I think we should be very careful as we go forward in time and keep an eye on these numbers, which way they're going. This is from Our World in Data. Again, a very useful resource. This particular graph I tweaked to look at the United States and Israel for their excess mortality since the beginning of the pandemic. This is 2020 till date. You can see the excess mortality has consistently remained high. And remember, Omicron came around this time, so it really has not changed much in spite of all of the vaccinations that have been given. It is perhaps because Omicron affected far more people than the previous variants did. So mortality has consistently remained high. And this green graph is the Israel mortality, which again, 0 is the baseline. This is the expected mortality from pre-pandemic days, and these are all excess mortalities. All of us know that in the beginning of the pandemic, there was a phase where there was lower mortality because fewer accidents, fewer shootings. If we are talking about the United States, shootings are a major cause of deaths in the United States. We know that. Very large number of people die from shootings, road accidents, so the excess mortality also came down from other infections also came down. So in the beginning of the pandemic, the excess deaths were lower. Now, the age curves have reversed. I'll invite you to read this article in the Washington Post by Dan Keating and co. This article came out 10 days ago. It is so beautifully written with plenty of data, real good data. This shows, I'll take you through the highlights. Now, this is April 2020, and this is present day, or April and May. These graphs look at different age groups. The gray graph is below 50. The red is over 75. And you can see during the 2021, that is January 2021 till January 2022, when vaccines, I think, were rolled out around this time. This is how the vaccines were rolled out. You can see the death rate among the older individuals dramatically came down, this part. And the death rate was primarily among younger adults. That's, let's say, 50 to 74 adults. So you see that? The death rate, because older people were vaccinated first, they were also more open to vaccination. They were more accepting to vaccination in the US. This is again US data. But you can see that in 2022, since the arrival of Omicron, the graphs have crossed. We now have predominantly older age groups that are dying, and the death rates among the younger or the lower age group has really come down. So that is something that was pointed out in this Washington Post article. That's why I wrote the statement. The age curves have reversed. I think they said again, these are trends we need to keep an eye out on. And the next point is Omicron does not give a lot of natural immunity. You know, many people have been dishing out statements based on no evidence but on comfort theories. I remember when Omicron came out, many scientists and doctors made a statement saying that this is nature's vaccine. No, Omicron is not nature's vaccine for many reasons. A, it is killing many people. We saw that. And B, unfortunately, it does not induce natural immunity like we thought it did. So that is something we should realize. Omicron is not a natural vaccine. It's one of the biggest hoaxes that occurred after after Omicron arrived on the scene. And these hoaxes were propagated by people of science, unfortunately. And this is an important paper from China that looked at BA1 infection, and they found that BA1 infection, the early Omicron variant, was not able to immunize the body against its subsequent variants. So what Omicron has been doing is, if it is 1, 2, 3, 4, 5 versions of Omicron, if all of these are Omicron, version 1, if you had version 1, version 2 is already outsmarting 1. And perhaps version 3 will already outsmart 2. So that is the way the virus is evolving right now. So since the arrival of Omicron, we are seeing this trend that the latest versions or the more recent versions are able to infect or get past the immunity by the earlier version. So this again goes against the principle or this hopium principle or the hoax principle of Omicron being nature's vaccine. Again, this slide may take a little bit of time to explain here. These are the B memory cell responses. B memory cell responses in vaccinated group, hybrid group, that's vaccination and infection group, and virgin infected groups, that is people who've been unvaccinated, who've had BA1 infection. You can see that in anyone who had vaccination or hybrid immunity, the B memory cells went on and latched on to the wild type receptor binding domains. That's 81.5 and 78.1 in the vaccinated and hybrid groups. But you see that number plummeted to 27% in the virgin group. I call the virgin group, that is basically BA1 infection in someone who's not been vaccinated. This basically shows that if you have a BA1 infection, it is not particularly good at anything other than BA1. So in other words, your BA1 will protect you against BA1. That's it. It does not protect you from anything behind, or it does not protect you from anything afterwards. So it stands on its own. It does not protect you from anything that occurred before or after. That seems to be the trend. I think that's the one-line summary of the slide. And they also found evidence of the original antigenic sin. I know it's a misnomer, but basically it beautifully explains why if you get provoked immunologically after stimulation in the past, your immune memory will remember the first stimulation. And again, the fact that the memory B cells gravitated to the original spike showed that there was evidence of the original antigenic sin here. So again, the next point, which I would like to cover as we close, as we come towards the end of my session, is that a vaccine based on Omicron, even though it sounds very attractive on paper, I know a lot of non-medical people are constantly tweeting about why are we not getting a vaccine that's based on Omicron. It's not so simple. And this Chinese paper actually puts out this statement, which I will read out. What they have actually said is the following. It's very elegantly written, this paper. They've said, in this study, we show that Omicron is continuously evolving under immune pressure with these mutations. Unlike when Omicron first appeared, now the sublineages have started to target humoral, that's antibody immunity induced by Omicron itself. So that is like Omicron attacking itself. So Omicron is smart enough to go back and escape immunity against itself. So the paper goes on to say that this poses a great challenge to the currently established herd immunity through wild type based vaccination and BA1 infection. Again, this observation also suggests that Omicron BA1 based vaccine will not be an ideal antigen for a broad spectrum protection against emerging Omicron sublineages. In other words, you create a BA1 vaccine based on your Omicron, it will be good against BA1. That's it. It might not protect against others, or hypothetically speaking, if Delta re-emerged, it will not protect against Delta. Now, when I say Delta re-emerging, it can be other variants coming out from other branches of the genomic tree. From any branch, such a variant can emerge, as we saw in the past. Some death trends I will also highlight with boosters. I know that field is quite murky because it's not an apple to apple comparison here, but I'll take you through some of the trends. Now, this study from Canada, Quebec, Canada, deserves plenty of attention. This comes from some of the most credible sources in Canada. This is an official database. It was published, it was posted on the 29th of April. I've basically summarized the hospitalization rate by vaccination status. The percentage of cases that are hospitalized by vaccination: unvaccinated, 7.9%, one dose, 3.7%, two dose, 1.5%, and then there was an uptick in the third dose group. Now, the same trend was noticed when I tracked the death rate. See, the third dose group had a higher death rate higher percentage than the two dose group. Now, I know this is just looking at data, and there can be plenty of explanations one way or the other. If we found that the two dose had a greater mortality than the three dose, then we will say that it is because the third dose protected more than the second dose. But the moment we see that the third dose is dying more, then we say it's because the sicker people received the third dose. So there's plenty of explanations for observations, all of which need not be true. So this is an area we need to watch very carefully with an open mind, which is why I use the word, is there a J curve? A J curve basically means any medication will have, even if it's for, whether it's for blood pressure or for cancer or for whatever condition, you use a medication, there is a limit beyond which it stops being beneficial, and then the harms may increase. So that is the definition of a J curve. So I'm not claiming that this is a J curve, but I'm saying that this is a potential that we must be watching out for. Whether too many might not be a good idea is a question. Whether it hampers our immune response is one question that needs to be out there to be answered. So we know that people who receive two doses are doing very well there. Okay. This again is the data that I used to calculate these graphs. This is again a small study that's out of Israel that looked specifically at people who were critically ill with COVID-19 and looked at their mortality rates. You can see that in the unvaccinated group, the mortality was 51%. In the three-dose group, the mortality was the same. So again, so all of these are pointers that we should really keep an open mind about about the vaccination and its relative benefits. Now, in this group, a small number of individuals, 88 individuals, much smaller than the 400 that received the other two doses, they showed a lower mortality. Again, we do not know if that's the benefit of recent vaccination, whether the people who were healthier went on to get 4 doses or vice versa. Again, this is all data. We can't conclude anything from that. We should keep an eye out for. And then the elephant in the room, which nobody likes to talk about anymore, is long COVID and brain shrinkage. It is very much there. And we've seen the UK Biobank study that showed paired mRNA studies showing that the brain is shrinking. There is more CSF or cerebrospinal fluids among people who've just had COVID-19, not even long COVID. They just looked at people who had COVID-19. And this particular study looked at 19 individuals who had long COVID, and they found that there was loss of gray matter for lay individuals who are non-medically qualified individuals. Gray matter is a part of the brain that is the evolved part of the brain that we use for conscious thinking, judgment, analysis, and so on. So that is gray matter. So gray matter has been diminished in this group of individuals. Vaccines don't have the same effect in all age groups. Again, this is straight out of CDC's death website. It's easy to track. This, I think, is from 30th of April. I've been tracking it for about 7 months thereabouts now. I'll take you through this graph again. This is subdivided by age groups. Here's 12 to 17. Here is 65 plus, and these are the intermediate age groups. This is deaths. You can actually click on deaths and select deaths as an outcome. And I'll expand this graph for you. If you look very, very carefully, you can see that there is a dotted line here. The dotted line that you see here are the 2-dose. The solid line is the 3-dose. So in the 65 plus age group, the 2-dose and 3-dose group are almost the same in terms of death rate, and unvaccinated, which the black line, is substantially higher in the 65 plus age group. So we know that in the 65 plus age group, adding a 3rd dose has some difference, but again, not much. You can see the 2-dose and the 3-dose group are really merging in the 65 plus age group. As you come down below the 65 age group, just look at the same graphs here. This is 0. This line is 0 here, over here. This is 0. On 0, you can see both the 2-dose and the 3-dose groups are both on 0. And the unvaccinated group is very close to 0 here. And below 50, all the lines are along the 0 line. You can see along the 0 line, you got your 2-dose, 3-dose, and the unvaccinated groups. So this again, this is not to suggest that vaccines don't work, but the graph very clearly shows that vaccines work differently in different age groups. That's precisely my point here. Less than 50, again, I reiterate here, based on the CDC's evidence on deaths by vaccination status, there's no difference in deaths between unvaccinated, vaccinated, or boosted below the age 50. And over 65, it's a different ballgame here. You can see there's a clear difference between unvaccinated and vaccinated. And even among vaccinated, there is, I can call it a significant difference here, especially during times of a surge, that the 2-dose group did worse than the 3-dose group in the 65 plus segment. And if you remember the paper I presented earlier from the UK Health Security Authority, that they showed that in the 65 plus age segment, those with 2 or more comorbidities showed a clear difference when they received additional doses. So again, these are pointers to who will benefit from additional doses. Again, I don't know if there's enough time to show that vaccine effectiveness calculation has been profoundly wrong by many papers. And I'll just take you through a simple example of how that can easily happen. So this is a paper that actually, again, is from the UK Health Security Agency. I'll show you very clearly how vaccine effectiveness can be falsely low if you just count incidental positives. So you see in the same group of 18 to 64, you can see the vaccine effectiveness of around 30%. And now I've looked at the same group. If you use a different outcome, again, you take out the incidental positives and you look at only those individuals who got oxygen or ventilation. You can see the vaccine effectiveness has remained the same over a period of time. So when you look at the wrong endpoint, if you include the wrong people in your analysis, you'll find that vaccine effectiveness is low, and it was increased after a booster dose. And you can see that it actually did not really make much of a difference when you only looked at those individuals who were genuinely ill from COVID-19. Again, so be very careful about interpreting vaccine effectiveness study. Having worked against hoaxes for years and years, I've debunked so many hoaxes over the years. I'll say this: denial or wishful thinking is not scientific. And unfortunately, wishful thinking I see happening from even people of science. This is again from the Washington Post article that I mentioned. I'll quote Professor Christina Pagel here. She says, "What we do in the pandemic affects the health of other people. and what they do affects our health. And this picture is so tragic. It shows the grief of an individual who has lost a near and dear one who was triple vaccinated. And you can see this. This is a picture of tragedy, and this is such a sad picture that COVID deaths is no longer overwhelmingly among the unvaccinated. The gap is shortening, the gap is narrowing. People who are fully vaccinated are also succumbing to Omicron, and therefore we can't stop using mitigation strategies. We see a lot of people worshiping this, say, for example, one particular intervention that we have produced that is against the pandemic, that's vaccines. There's no doubt that they have really reduced the amount of severe disease and reduce the number of deaths worldwide. But blind worship is not the way to go, because vaccination is only one of several layers of the Swiss cheese model of this. If this is the virus that is trying to reach this human being, you got to put as many roadblocks as possible before. And if you just put one roadblock, that is vaccine, we will end up being in a place where many developed nations are right now, because they went through that single layer model, saying that if you're vaccinated, all is well. It does not work like that. So this is not to be misunderstood that vaccines should not be used. Vaccines are helpful, but they have certain limitations, and we must acknowledge these limitations with all humility and add all these other layers: physical distancing, stay home if you're sick, cough etiquette, hand hygiene, not so much. Again, that is overemphasized. Wearing a mask, especially a high quality mask in indoor spaces when we share the space with strangers. The smaller the space, the less ventilated, the worse it is. Avoid touching your face. If crowded, stay away from crowded indoor spaces to the extent possible. Switch to digital meetings. The meeting we are having right now is an example of how we can use technology for transfer of knowledge or discussion without subjecting ourselves to the risk of exposing to the virus. Sensitive test and tracing, ventilation, switching to outdoors, air filtration, important communication, very, very important to communicate. You remember the controversy about masks being used in India. When we removed the penalty for wearing masks, even though it was done in good faith, the public unfortunately took it as a license or a message to stop wearing masks. So we must be very careful in our messaging. Even though technically we may be correct, the end result was when people stop wearing masks. So again, communication, which again, I'm a trainer. I'm the communication skills trainer for IMA Kerala State Branch for the last 7 years, except for this year. So communication is an extremely important part of the pandemic, and being true to science is not enough. We need to communicate all of these facts clearly to the public so that their actions will end up protecting the society. So I'll end by some photographs that I took on one road trip in the state of Kerala, Cochin, recently. It shows the amount of mask wearing in this part of the world. These were random pictures. So here is this gentleman who's happily walking. Here, there's a man that's walking. Here's a man that's walking with a mask. A nice woman who's walking in the hot sun with an umbrella. Man crossing with a mask on. Gentleman walking along the pavement with a mask on. Two young women walking with masks on. Here is a couple, I think mother and son, waiting to cross the road. That's a zebra crossing. Both have masks in place. Again, I think I'm not implying that everybody outdoors should wear a mask. This is not the point, but the point is that if masks are an important mitigation strategy of reducing the infection rate. We know that vaccines are not very good at stopping infection. And in an indoor space that's ill ventilated, there is no substitute for a mask at this point in time. So I will stop now. The time is 7 p.m.
Thank you, Dr. Rajeev, for the quite information-packed session on the evidence on both vaccines, breakthroughs, as well as a bit of reinfection. And to rightly summarize, you also put together the very relevant points on how the world should now think beyond vaccines. And as we move to a next level of the pandemic, where we move from the concept of risk at the population level and move to a concept of risk at an individual level, what we should do to actually mitigate the risk. And the last slide was the most important. As individuals adopt the non-pharmacological interventions, which are quite effective in many ways, probably more effective than vaccines to prevent infection. Now, in your opinion, how do you see the next phase of the pandemic with a lot of individuals moving to a risk mitigation strategy where the risk is at the personal level rather than at the population level?
Well, if we look at the history, we have the advantage now of looking at 2.5 years of how the world has faced the pandemic. There's no doubt that these waves will continue to happen. As to what shape they will come in, we do not know. There's a view, this is again your realm than mine, Vinod, that Omicron is a different animal compared to the previous variants, and its sublineages may behave differently. So those are questions that are out there as to how BA4 and BA5 will behave. You had warned about these mutations. Those are your area than mine. I would watch this very carefully, and I would watch Dr. Tulio de Oliveira's updates and also Professor Abdul Karim's updates from South Africa, because that is really where things are happening at this time. In the US, they have a different sublineage. As you wrote today in the Hindu, I read your article and Bani Jolly's article. You wrote that there are so many sublineages that Omicron has produced, just like Delta had produced so many sublineages that you yourself had described very elegantly for us, Vinod. So we'll just have to wait and see. And I am no one to make a prediction. All I know is that it's going to continue. As to from whatever material I presented, I believe that the longer we wait after a dose of vaccine or a natural infection, the more susceptible we become to the next wave. I think India is now about 3.5 months out on average from the BA1, BA2 wave we had, which is perhaps why we are not having a huge uptick in cases. South Africa is 2 months behind in terms of, in India, their wave started mid-November last year or late November. So India, we peaked around third week of January. So we had a 2-month, let's say, difference with South Africa. And India and South Africa both have substantial amounts of population immunity from natural infection. And increasingly, we are finding data coming in that hybrid mode of immunity, regardless of its critics, there are plenty of critics as well. Regardless of its critics, these countries are doing relatively well. So we'll just have to wait and see. I think people like yourself and others who are in this forum, who are scientists, who are watching these variants as they come along, genomic sequencing and passing the information on. I think we look up to you to guide us.
Yes, so we have a few questions, and I hope over the next couple of minutes we could take probably a limit to just a question. And this question is, in the light of all this data, what are your recommendations for the vaccines? If in a certain part of India, variant BA-X or Y is dominating in circulation, I don't know. I mean, it's a bit unclear.
Okay. So I think the question is
what are the
clear.
recommendations?
Yeah. Given the prevailing conditions, what are your recommendations about the vaccines? So I'll give you the established facts first. So if we have received 2 doses of vaccine, why is 2 important? 2, basically, again, for the non-science-based viewers here, The first dose is called a priming dose, and the second is always called a booster dose. But that's not a third dose. The second dose, when it's given, it builds on whatever the body has produced after the first dose and creates what is called a long-lived bank of memory cells, and that does not form with one exposure. So that is why almost all vaccines require to be taken in at least 2 doses. Whether more doses will increase, that we do not know. The opinion is divided on that. So back to our question, if you've taken 2 doses of vaccines that are available in India, you're well protected against severe disease, simply because you're not immune naive. You have created a bank of B cells and T cells, genre of memory cells that are living in your bone marrow, which are constantly on the lookout for anything that resembles the old virus. It does not have to be the old virus. Many people are concerned that, oh, these vaccines are made of old virus. The virus has mutated so much. How will the vaccines protect us? And as the scientists in this forum know, these changes that occur in the virus are in very, very few select parts of the virus. And our immune system has the ability to recognize all the main parts of the virus, regardless of what the variant is. So agreed that vaccines may not stop us from getting infected, but they will protect us from severe disease, at least until this day. If that changes in the future, yes, we will write about it, but there's no indication that any of these variants are evading our vaccines in terms of severe disease. But that does not mean that we should indiscriminately walk around, drop our guard, and pick up infections. Remember, number of deaths is also a function of the number of infections. It's plain math. If in a community there are 1,000 people who are infected, in another community there are 10 people who are infected, guess where the deaths will be more? Regardless of vaccination status, it is a community that has more infections. And the way to stop infections is what, as Dr. Vinod Skaria said, all the mitigation strategies. When all the strategies come together, only then we can reduce the number of infections. I often draw a parallel to cholera. We live in a world now in India where cholera is so rare, it becomes a matter of historical perspective. Why? Because our water supply has become so much more, public water supply, at least in most parts of India, is so much improved. The germs are all gone. We have better hygiene standards. So that is the reason why we have much fewer waterborne diseases than we had before. And this virus spreads through air. So multiple strategies that improve air hygiene are the way forward, in addition to vaccination. As to additional doses, I would go with what the authorities state from time to time. There are some individuals who are vulnerable, who will require more doses. And there are some who are at low risk, who may not need those doses as much as the others.
Yeah, thank you very much. I think it is very, very clear. And to summarize the 2 points, 1, vaccines are effective. And second, we need to also look at and embrace the other aspects of preventing infections beyond vaccines as much as we take our vaccines. Thank you very much. And thank you for the nice evening of data-packed and evidence-packed